introduce Anna Kahkoska from the University of North Carolina, who's going to present our first poster, Longitudinal Phenotypes of Type 1 Diabetes in Youth Based on Weight and Glycemia and their association with complications. Anna?
My name is Anna Kahkoska. I'm an 8th year MD PhD student at the University of North Carolina at Chapel Hill, and I'm excited to get to present my poster today, which is titled Longitudinal Phenotypes of Type 1 Diabetes in Youth Based on Weight and Glycemia and their Association with Complications. And the co-authors that helped me with this work are listed here, and this has been published. So the background here is that the prevalence of overweight and obesity is increasing among youth and young adults with type 1 diabetes. And we also know that subclinical and clinical complications emerge early in the natural history of type 1. A gap that we identified is that the interplay of obesity and glycemia as risk factors for those complications was not really well studied, and particularly in pediatric populations. And so in the precision diabetes medicine framework that's been outlined, this is an interesting precision prognosis question, which is to ask, can we more precisely predict what's going to happen, these disease-related outcomes, using information that we know about people like their weight and glycemia? Our objective was to first identify these subgroups sharing similar patterns in weight and glycemia, which I'm calling longitudinal weight glycemia phenotypes, and then testing how those subgroups are associated with the emergence of different early and subclinical diabetes complications. For this analysis, I used data from the Search for Diabetes in Youth cohort study, which is a US-based study. And I took advantage of 2 time points. We have data from a baseline visit and then data from a cohort visit that happens 5 years or more after that baseline visit. I included youth with type 1 diabetes with complete BMI, Z, and A1C measures. And then we clustered people based on their measures of BMI and A1C at the baseline visit and the cohort visit using a version of k-means clustering. And once we had clusters, we used logistic regression modeling to see how those clusters were associated with different complications. Just showing a subset of the results here, we identified 4 longitudinal weight glycemia clusters using data from 570 participants. There's a lot of different ways to look at these clusters. Here I've shown them as trajectories of BMI and A1C between the baseline and cohort visit. And I'm just going to point out this group in purple, they had the lowest BMI and A1C at both time points, and so we call them the referent cluster. This green group had a very high A1C at both time points, and we call them the hyperglycemia only cluster. When we looked at the complications at the cohort visit, and these are compared to the referent cluster, that group had elevated odds of developing dyslipidemia, retinopathy, as well as diabetic kidney disease. The other group that was kind of interesting is this yellow group. They had a high BMI Z at both time points with increasing A1C over time. You can see that here. And when we looked at the complications, that group had elevated odds of developing hypertension, dyslipidemia, arterial stiffness, as well as 2 or more comorbid complications. So the takeaway here is that we found evidence for these different phenotypes based on BMI and A1C that really diverge over the first decade of having diabetes. And we also found evidence for different associations with different complications between those subgroups. I think this speaks to the potential utility of incorporating obesity measures into clinical phenotype of type 1 in youth for precision prognosis, specifically as it relates to complications. And when we start to think beyond precision prognosis, the heterogeneity that we see across these groups, both with regards to phenotype and outcomes, suggests that we may need to be thinking about precision treatment and prevention strategies to really accommodate the unique needs across those subgroups. And I'm happy to take questions. My contact information is here.
Oh, Anna, if you can stop sharing your slide, that would be helpful here. Keep in mind, everyone, that we can ask questions to the chat room. And I have a question for you. Did you incorporate data related to weight loss before the initial diagnosis was made? And might that confound your interpretation some?
It's a really good question. I didn't have that data available to me as part of the Search for Diabetes in Youth study. One consideration that we made as far as thinking about weight loss and then weight regain is that we excluded the participants who had a baseline visit that occurred within 12 months of diagnosis, because we really were trying to capture these phenotypes based on established type 1 diabetes. So the goal was that we could exclude some of the variability that may speak to more severe or less severe weight loss preceding diagnosis by doing that.
Okay, thank you. And a final question relates to, were there relationships consistent across ancestries? Did you look at that?
Could I get some clarification on what that question means?
Well, that's the question I'm posing you. That's the question that's been addressed. So if you could answer that to the best of your ability.
So we didn't have a really rich data set to look at ancestry specifically. We were able to look at race and ethnicity as part of our logistic regression modeling. So we did adjust for that when we were looking at the associations between clusters and complications. But I think it's an interesting question that probably warrants a lot more investigation.
All right, good. Thank you very much, Anna.